The Lord be with you.
With your spirit.
Holy God, guide this conversation. And we give thanks for Dr. Shan's wisdom and presence with us today to help us to know in unknowable times. And we hold before you our desire to know and pray for patience and also really wisdom in knowing how to proceed in this time. May our care for one another be first and foremost on our minds, and that all we do may praise and glorify you and edify those around us. Be present in this conversation and incline our hearts to you, that we may know you more fully and love one another more deeply. It is in your name we pray. Amen.
Amen.
I'm very glad and honored to welcome Dr. Jessica Shand. She's a physician and clinical ethicist and theologian whose areas of practice include pediatric blood disorders, blood disorders and immunology research, moral distress, mitigation, and healthcare. This is a very long bio, Dr. Shand. She's associate professor of pediatrics and medical humanities and bioethics at the University of Rochester Medical Center and teaches on the adjunct faculty at Colgate Rochester Crozier Divinity School. She has been with us before, and I'm very honored to welcome her back to talk with us in this time. And so, Dr. Shand, welcome to be with us.
Thank you so much. I'm just incredibly grateful to be here, to be able to share with you, to be able to answer any questions that I'm able to. Some of my answers may be I don't know, either because I don't know or because we don't know, or all of the above. And so to have this ability to also sit with you in uncertainty in a faithful way, which I think is one of the hardest challenges for all of us right now, particularly as we progress through this liturgically so deeply significant part of the year. And so I'm just going to share my screen. Right, so when I spoke to you last March, the title of my talk was COVID-19 and Faithful Response, and I added again and ongoing. And one of the things that I've been talking quite a bit about with the Reverend Dr. Melanie Duguid-May, some of you may know Mel from her pastoral work in Bath, but also as a professor at Colgate Rochester Divinity School. She and I are going to be reteaching our pandemic and faithful response class this spring, and we were sort of really digging deep into faithful response of this chronic endemic phase of COVID, and how that is, what the similarities and differences are to what we experienced a year ago, or just under 2 years ago, when we first entered this crisis of health and also of the spirit in the community. So I just want to share with you, without getting into too many details, I think it's important for us to know where the most updated data is. So this is the New York State COVID data tracker, and just is a place that you can go to get overall case information, to get trends, and now increasingly you can also get data on variants. Because we're starting to be able on a larger scale to test for Delta variant, Omicron variant, and other variants to get a sense of how much of that is in the community. But I think it's just important to make the point, and it's a somber point, and it's a point of prayer and reflection, that, as many of you know, we recently passed the 800,000 mark of people in the United States who've died of COVID-19. I am also sad to share with you that over 3,000 children have died of COVID-19 since the beginning of this pandemic. And so we just continue to feel the effects of this. So some of the questions that I tend to receive, particularly around the planning for holiday gatherings, so I want to be focused on what I know is close to all of your hearts today, is what do we know and what don't we know about these virus variants? And I think it's important to be able to articulate what we don't know. And here is where I do tend to see a little bit of a lag between the scientific facts and what gets reported in the popular press. So these slides, I wish I could claim credit for them. They come from the Johns Hopkins School of Public Health. You're going to see me cite a number of things from Johns Hopkins School of Public Health. And in full disclosure, I'm a graduate of that institution, and I just have a tremendous amount of brand loyalty to my alma mater, but they really have the expertise and the ability to know a tremendous amount about these issues. So what do we know? We know that Omicron is a variant of concern. Well, what makes a variant of concern different from other variants? It seems to be able to infect and accelerate through the community. And we know that there may be Omicron appears to be more efficient at transmission from person to person. I think the larger questions that surround that are, does increased infectivity or transmission of the virus necessarily translate into people getting sicker? And that's what we don't know. But what we do know at this point is that, yes, there are people who were fully vaccinated for COVID-19 who have been infected with the Omicron variant. We also know that the vast majority of vaccinated individuals who are infected with the Omicron variant have a mild disease course. So the vaccine is doing its job in the sense of preventing serious illness and hospitalization. There does appear to be a benefit of the booster vaccine for adults, and particularly those who may have immune suppression or other things that make them more susceptible to significant disease. So we're going to be hearing, I think, more guidelines about that, and folks are being encouraged to get a booster vaccine if they're within the window, are eligible to do so. But this really is, we are learning in real time. And I think what makes it challenging to faithfully respond to uncertainty and learning in real time is that we may get information tomorrow about infectivity or disease prevalence or vaccine effectiveness that may seem different than what we heard 2 weeks ago. And that is does not necessarily mean that the information was false. It means that we're learning. And so I want to be responsive to questions. Someone asked, I have parishioners that are hesitant to get boosted because they fear it's not fair to people who haven't been vaccinated yet. Do you have a good response to this problem? I do, because this is what my medical students ask all the time. And I guess I've done my job, because I've drilled global vaccine equity and justice into their minds as their bioethics instructor from day one. So now they're asking the right questions. Global vaccine distribution is a really complex economic and technological problem. I think that and I can share more resources about that. My short answer is that folks getting the booster vaccine within the next few weeks to month from available Pfizer, BioNTech, mRNA vaccine stores that are here is not meaningfully contributing to vaccine inequity globally, right? So like those doses have already been purchased. They're already here. They wouldn't have otherwise been shipped elsewhere. And so that's a difficult answer. It's an inadequate answer, because really we should have a system from the beginning where there's sufficient vaccine stores that are deliverable to everyone who needs them. But the short answer is that folks should not feel hesitant to get boosted because there isn't a direct correlation between what they might receive in the next few weeks and someone somewhere else in the world not receiving it. But at the same time, we have to put pressure, particularly on the companies, but also on folks, World Bank, WHO, that are sort of overseeing and legislating global vaccine distribution efforts to ensure that resources are managed in that way. And so, yes, global vaccine equity is a problem. It's a complicated problem. But the immediate effect of local folks getting a booster now and through the holidays is vaccine that we've already purchased, and not receiving it isn't going to mean that somebody else who needs that dose somewhere else in the world is going to get one. And so, and the last question, do we have a good response to this problem? Really is a large economic and governmental oversight response internationally, and I'm happy to provide some expert commentaries and more information on that subject after this talk. The second question, nasty flu outbreak right now, absolutely. Influenza A is fairly prevalent in the community. And we should be concerned about that for three reasons, really. One is, and I was going to get to this later in my talk, but many of you may know our hospital systems are overwhelmed. I am just going to be honest with you that I'm going to try to keep it together here, but I'm scared. I'm scared with how busy our emergency departments are. We are short-staffed. The folks who are left behind after the mandates and after just a lot of folks burning out, a lot of folks feeling distress, a lot of folks feeling like they just can't go on because there was a human solution to some of this, and it's still happening. The human solution being vaccination and social distancing and other things. And so so I'm worried about it in terms of community health. Because COVID and influenza co-infections can be potentially very serious, just because influenza itself can be a serious disease. I will tell you that the influenza vaccine for this year, the seasonal influenza vaccine, is a good match for the flu that we're seeing in the community. Sometimes the flu vaccine isn't the greatest match. The forecasting doesn't quite get it right, but we're finding that folks who are vaccinated for influenza seem to be protected from moderate to severe illness. What we've seen certainly on college campuses with large influenza outbreaks are mostly in unvaccinated individuals. So we should be concerned in terms of the burden on healthcare systems, how an overrun healthcare system is going to trickle down to other healthcare needs that folks have. We're seeing elective surgical procedures temporarily put on pause. We are starting to see now, a year and a half into this, the effect of delayed surveillance, routine colonoscopies, mammographies. People need to continue to do their screening tests, but the healthcare system is becoming more inefficient. In pediatrics, we've been dealing with an epidemic of a virus called RSV, respiratory syncytial virus, which is particularly an issue for babies that have been in the neonatal intensive care unit. We've been dealing with that since August. And so just the combined effect of the other respiratory viruses that make up the virus season in a hospital not necessarily going away. And so worried for health, worried for healthcare systems, worried for resources. So in terms of vaccination, masking, social distancing, we know from last year's experience with influenza that widespread masking and social distancing did an awful lot to curb what we usually see, the spikes in influenza that we typically see. So thank you for those questions, and happy to follow up with more. So what we know, what we don't know. At this point, we don't know how widespread the Omicron variant is. I do want to caution folks, there's some sort of, there's a lot of dialogue that Omicron variant started in South Africa. It didn't necessarily start in South Africa. South Africa just has a highly evolved public health system, and they do a lot of routine surveillance testing and extended surveillance testing in their community, as well as a highly mobile population of folks that are moving between South Africa, Europe, and other parts of Asia. And so that's where it was first detected. That doesn't necessarily mean that's where it originated. But it's really important, a little science 101 for you to know, just like cancer cells, viral genomes, virus cells are just inherently unstable. They divide quickly. Their genetic material is less regulated than, like our healthy cells. And so there are going to be mutations. That's what viruses do. Influenza does it every year. I think with COVID, what's a little more sinister and a little different is just how quickly this virus has been able to adapt and change. And so there are other variants out there besides the original two variants and the Delta variant and the Omicron variant. What makes a variant clinically significant is when it seems to spread quickly in a population. And that's going to continue to happen as long as we have susceptible pockets of folks, unvaccinated folks, susceptible folks around the world. And that is, again, a complex problem that ties back to vaccine inequity, vaccine hesitation, and what it takes to actually achieve herd immunity. And it looks like we're going to need a lot more to achieve herd immunity from COVID than we did, for example, perhaps for smallpox. But a lot of this is just unknown. I just want to take a quick minute, if you are ministering to any folks in your community who are hesitant about the Pfizer vaccine, about the mRNA vaccines, and particularly the fact that mRNA technology is new and there was an emergency use authorization and that's got pushed into the community too quickly. There are some really great resources out there about the fact that mRNA vaccine technology has actually been around for about 4 decades. And I think it's the future of virus vaccines and also cancer immune therapies and cancer vaccines. And that's outside the scope of this conversation. But it's really important for you all to know that this technology actually isn't new. The mRNA vaccine approach is not new. What's new is that, so this really elegant technology, a small message that gets into an immune system cell and says, I'm going to give you the instructions to make just the right small part of the COVID spike protein, the thing that gave it its name, coronavirus. And just that little piece of protein for you to make, not even the whole protein, just that little bit of the protein is enough to tell other cells of the immune system, hey guys, if you see this, it's bad and you should eliminate it. You should do something about it. And what I think is important to know is that making those messenger RNA sequences is old technology. What's new is it was really hard to get those tiny sequences into cells and have them stay in a way that could be useful. And so the little lipid particle, the nanoparticle, not nanobots, but nanotechnology, that packaged that sequence into a little lipid particle, a fat particle that gets taken in by the immune system cell. That was the innovation. People have been waiting, for decades to figure out how to make this work. And it was really the lipid particle, the little fat droplet that brought this into prime time. And so that's the innovation. These vaccines have been tested extensively. I've looked at all the pediatric data on safety and efficacy. I'm proud that both of my children are vaccinated. I had no hesitation whatsoever to do that. One age 12 who got adult dose and one age 10 who got the pediatric dose. And I think it's really important. I get a lot of questions. mRNA sounds genetic, sounds like it might interfere with people's DNA in ways that they're not telling us. Can it cause infertility? Can it cause cancer? And I'm not going to bore you today with why that's not possible, although I have a very extensive molecular biology answer as to why that's not possible. But it's not possible. All that little mRNA is just a little set of instructions to certain cells of the immune system how to make a little piece of that spike protein to tell your T cells, hey guys, this is what this COVID thing looks like. So if you see it again, you know what to do. And then it goes away. It doesn't get involved in your DNA. It doesn't get involved in your sperm or your eggs. It doesn't get involved, it can't, in cancer gene regulation. And I think it's just really important for people to know that. So some other questions I got from the community, from you all, and I thank you so very, very much for that. Recommendations for temperature taking. This was hugely, I don't want to say controversial, but you may notice that there's less of the temperature taking that's happening. We're not doing it routinely in the schools. And so the current recommendations for temperature taking are certainly fever is a sign of COVID-19. But not everyone who's testing positive from COVID has had a fever. And what we would call the predictive value of temperature screening is not as reliable as I think we had hoped. And so, and it's cold outside, and sometimes like you may have a fever, but you've been cold outside, and then the child walks into school. I can tell you that I've seen multiple children and adults test positive for COVID that never had a fever. So more common to have a fever, but the predictive value isn't great. And so by and large, organizations, there isn't enough data to support routine temperature screening. So coming into church, we're not doing it in faith formation in my parish. We're not doing it in any of the public schools. Rochester City Public School is no longer doing temperature screens. Certainly, if you've been exposed to COVID and you have a close contact with COVID, you want to monitor yourself, and one of those things is temperature taking. But by and large, the role of the large-scale temperature screen, I think, has fallen by the wayside because we know there are positive cases where there isn't a fever, or the fever comes later after the patient's already infectious. So thoughts about gathering with food such as church coffee hour. What in any ways should churches be different from restaurants? And so I'll break those two questions down. I think that so there are no set regulations right now regarding, so nothing from CDC, nothing from the counties or from New York State about whether or not we should gather with food. But I think I just want to express some caution, and particularly if you have congregants or parishioners who've not received a booster vaccine, or you don't know their vaccination status relative to question 3, or are just vulnerable members of the community. The old rule of you have to be less than 6 feet for more than 15 minutes may not apply to the Omicron variant. The Omicron variant may be more infective in less amount of time. It may also not make people as sick, particularly if they've received 2 doses of vaccine, but we don't really know that. So as congregants and faith leaders, you would not be wrong to come up with alternatives to sort of close gatherings for coffee hour, considering having coffee with lids, giving out to folks, having folks stand 3 feet apart or more if they're going to take their mask down to drink the coffee. But I would caution against close, unmasked food sharing during this time of year, even if folks are vaccinated, just because of what we're starting to see in the community. Now, that's my opinion. That is not coming from any state regulation, and I'm happy to talk more about that. If you're having those things, it doesn't mean that you're doing anything wrong. I'm just letting you know some of the things that may be a little concerning. And in full disclosure, I take a lot less, I'm trained to work with children who are profoundly immune suppressed. I'm willing to take on less risk, maybe even than the average physician. But just some things to think about. In what ways, if any, should churches be different than restaurants? I think, restaurants and bars, well, bars are like their own thing because people gathering we know that's been a recipe for disaster since the beginning. I think that, in a restaurant, you have people sitting for longer periods of time. You have people talking over tables. And that may be a higher risk situation than a coffee hour or a sharing of snacks. This question may have come in before the mask mandate was reinstated in New York. So as you know, as of this Monday, December 13th, Governor Hochul has re-invoked an indoor mask mandate. So in that regard, churches aren't any different than restaurants in the sense that if we're going to be inside, folks need to be masked. Certainly I know that parishes have guidelines about communion and how that can be done safely and effectively. And it may differ from place to place. But at this point, anything that involves people being indoors requires a mask. How can we assure safety if we don't require vaccination for public worship? Right. So in some ways, the mask mandate makes the answer to that question slightly less complicated. But I think there are still, I got asked after the last session about singing. And I think singing needs to continue with masks on. And there are I saw some amazing things at Hochstein, at the Hochstein Music School. I went to a socially distanced holiday performance, and the flutists had special masks they stuck the flute inside the mask. It had 2 slits on the side, and then they had little covers on the end of the flute. And they were standing apart. It was amazing, though. It sounded incredible, beautiful traditional Christmas music. So folks are getting creative, but I think faces need to be covered. Distancing should be continued. And the hard answer to that question is you can't assure it. There's no zero risk. And especially because we may be dealing with variants that are more infective, and because we're going to be dealing for the next month or so with a population that is more mobile, people are doing more gathering, they may be traveling, they may be in higher risk situations, you can't assure safety. You can only require that folks wear masks, recommend that they do not come to church if they have any contacts who are under suspicion for COVID. And I would caution you as well, home tests are generally accurate, but there are cases of folks who have been in contact with folks with COVID who've tested at home negative and then a few days later developed symptoms and tested positive. So how you test and how suspicious you might be that you could be exposed to COVID, we call that in medicine pretest probability, does affect the accuracy of your testing. So if you have any suspicions whatsoever and you have symptoms and you have a home test that tests negative, I encourage you to speak to your healthcare provider about whether a nasopharyngeal, a COVID PCR test is needed for follow-up. So I would really love I want to be mindful of your outline of your time. I'm here, so if there are any other additional questions about safe gathering and about the holidays, I'm really happy to answer them. And I see folks in the chat. Gretchen, during our Christmas Eve service, we sing Silent Night with lit candles. We purchased bell-shaped snuffers to extinguish the candles instead of people to unmask and blow out the candles. I think that if folks are, I don't know if you are able to get some distance from the people doing the snuffers. I don't know much about snuffers other than what they look like. But I think, briefly taking the mask down, using the snuffer, blowing it out, putting the mask back up, is probably okay. I've never tried to blow out a candle with a mask on, but they're made of paper, and I just worry about other things happening. And so, yeah, it would be great to see the link. I know that the Rochester City Ballet, their angels carry candles. And what they did, and first of all, for safety reasons, but something they did for all the angels this year was have candles that were not actual candles, but just, battery lit up LED candles, and they just got turned off with the button when it was time for the candles to go off. And then that was safe, but also didn't involve anybody blowing on anything. And these were mostly children who, including my son, one of my sons, that, can't necessarily be relied upon to blow responsibly. People are weary. Yes, pandemic fatigue, weary hearing about this pandemic. What is the best way to gently encourage compliance and vigilance for health? I feel that, and I have such tremendous compassion for that question, because we are all so weary. And I have to say, I've been thinking about this so much. Like when I think about so much of the Old Testament being born of exile and struggle and plague, and it's like things just keep coming even when you think it's over. Things just keep coming back, right? We're exhausted in our souls. As opposed to the ancient times, we have access to news 24/7 news feeds. And so I think the gentle encouragement and vigilance for health just has to come from a place of love, and being just really shamelessly unapologetic to your congregants, to the people that you minister to, that as exhausting as this all is, we need you. We need your energy. We need everything that you give to this faith community. And we have to look to our faith to give us the strength to move through this exhaustion. This is certainly a trial. And we have to remember that as the faithful, it may not feel this way, but God has prepared us. God gives us what we need to be strong. Sometimes we just have to listen, and we have to hold on to one another. And, I don't want to say it could be worse. We could be in the desert for 40 days living off locusts, but as the case may be, right, we have each other, and we are able to connect, even though we're not all connecting in the ways that we want to. But God gives us the strength to fight through this existential fatigue, which for me is the hardest part. It's much harder than like the physical fatigue I feel walking into the hospital every day is no match for the existential fatigue. And then I love these questions because this is what's on everyone's mind. I suspect the answer to this is going to make me tired. Do you have a ballpark estimate of how long we should anticipate COVID and its variants sticking around? And the answer to that is that I don't know. I don't think that anybody knows. What we are getting a better sense of, though, is what information we will need in order to make that estimate. And the information is, how quickly we can get more people vaccinated, the effectiveness of boosters and modifications to the vaccine to give enhanced protection about variants as we begin to understand variants, and herd immunity. So it's, Brooks, I wish I could tell you it will be 6 months. It will be a year. We've had some really encouraging developments, though. The fact that folks, particularly folks in healthcare, who've contracted, I don't like to call it breakthrough COVID, because it didn't break through anything. The vaccine did its job and kept you out of the hospital and off a ventilator. But folks who have gotten COVID after 3 doses of vaccine, the courses really seem to be milder. And the main concern there really is that you're still contagious and can still spread it to others during that time. But I think the fact that we know that there's effectiveness in our vaccines, that we understand the problems we have to solve in order to get to that place, as opposed to March 2020 when we had no idea. And March 2021, where we still kind of didn't really have any idea. We were just learning incrementally. I think we're going to see masks for a long time. And I think, again, I thought it was very strange 3 or 4 years ago, before COVID-19, before SARS-CoV-2, I would notice on the University of Rochester undergraduate campus, I don't want to say a majority, but a large proportion of our students from China and Hong Kong and Taiwan would wear masks in the winter. And I was like, what's the deal with that? And the deal with that is that they all lived through SARS. And part of the culture had mask culture, had been an accepted, for some folks, an accepted way of keeping oneself safe. So we may be seeing masks for a while, but I think we just don't know. Assuming people will be traveling, additional testing precautions that should be taken by either those who have traveled, or parishes. Again, I think that there has to be some logical strategy to testing. I think that if you are gathering with family and you know that you will be gathering with individuals who are not vaccinated, then it is probably a good idea to self-test. Again, that testing, you can't go to a county testing site or necessarily your primary care physician's office to get a test without having a close contact with COVID or symptoms yourself. And so, again, access to home testing. And we may be hearing more about this. But I think if you are traveling in a crowded airport, you might consider it. There's no guidelines around it. But certainly if parishioners are gathering with family members who are unvaccinated, that would be a strong consideration for them. Whether or not the parish requires folks to test negative before they come back to a gathering, I don't know that we're at that point where health regulators are making those recommendations, and I don't have the data to suggest that or not suggest that. But I do think people should have a sense of what the riskier activities are. I think international flights, those that are allowed, being in close contact with family members who are unvaccinated, those are things that we should consider. Going back to singing, do we have info now about efficiency of masks in cutting spread to singing? My understanding is that if you are singing with masks, and there's some attempt of social distancing such that people are not right on top of one another. I don't know if it's 3 feet. You may be able to go back to singing. And the reason I mention that is because the public schools, children are singing in middle school chorus, and elementary school chorus, and high school chorus with masks. There are modifications. The Rochester City Public School District has kids on the stage 3 feet apart with masks. And so I would say the safest is 3 feet apart with masks, absolutely with masks. And I think that is, again, somewhat reassuring. We don't have data on whether or not that's going to cut down the spread of Omicron variant because we just don't have that information yet. But vaccinated individuals standing 3 feet apart with masks singing, I think is not an unreasonable approach. And then, yes, this being chronic endemic phase, can you go a bit deeper into what that means? And I mentioned it when someone asked the question of how long. I think that, I do think that we are going to see, I don't think Omicron is going to be the last variant that we see. The virus is just trying to survive. Just like we're trying to survive, right? So the virus is going to do whatever it needs to do to infect as many people as possible until it becomes impossible to do so. And when you add on top of that the intrinsic genomic instability of viruses and the fact that we as a global society are much more mobile than we ever were before. We gather more, we travel more. Gone are the days when your whole extended family lived in the same town as you. Maybe not gone, but it's much more common for folks to travel over holidays than not travel over for holidays. And so I think that even if we have variable definitions in public health about what endemic is, right? So influenza, there's seasonal influenza every year. Will there be seasonal COVID every year? Possibly. But I think it's important to consider sort of the endemic model of COVID so that we can begin to, it's paradoxical, but in some ways begin to address the COVID fatigue. And sort of shift our thinking from when is this going to be completely over and we can throw all our masks into the purification fire and do whatever we want and sing the hallelujah chorus, piggyback ride on another person that we love, and celebrate with wild abandon. But how do we really think about this as a chronic adaptation? And again, in faithful response, difficult as it is, what is continued spread of the COVID virus telling us about the unsustainability of many of our social and environmental practices? What do we have to learn from our, hyper-consumer culture? What are our roles and what can we do? And so I mentioned that endemic concept both as a likely reality for the next year or two. We may be dealing with this, not on the same surge scale that we're dealing with it now, but it may be seasonal, like influenza and RSV and adenovirus and enterovirus and lots of other viruses that we deal with. It may not be as life-threatening once we have vaccination and antiviral strategies in place, but to begin to accept its presence in our lives and adapt and think about what that adaptation really means and what we have to learn from it. That's no consolation to all of us who want to take our masks off. It's no consolation to me who worries about early childhood development and just sort of the need for children to be able to see words being formed as they're learning speech, the need for connection. But I think it's going to test our strength as a society if we are able to let go of our anger about when things are going to go back to exactly the way we wanted them to be before, and learn how to adapt. As so many of our ancestors in so many difficult situations had to learn to adapt. And so I encourage folks, it's an uncomfortable place to be mentally or pastorally, particularly around Advent. So maybe wait until after the Epiphany, but I encourage folks to think about, how does our community gather around the possibility of long-term adaptations for this, and how do we do that? How do we do that in a way that actually brings us closer and more ecologically and socially and culturally sustainable than we were before? And I think to not think about that is to potentially miss important messages from God. And so, yes, but wearing a mask in public, you can't see me scowling. Yes, my adolescent son is milking that one for all. There's a lot of scowling and faces that I can't see, but I know they're there. Instead of parents and teachers saying that they have eyes in the back of their head, I can see through your mask. No, it does not conceal the eye roll. No. So any other questions about gathering? I think framing gathering as that making these adaptations for the health of our community, for the health of others, looking out for the most vulnerable among us. There's a strength and a beauty and so much from the Gospels that encourages us to do so. And sort of being able to reframe those adaptations as faithful response, I think, is so important long term to the health of a congregation. It's not the first time we, the church, have had to adapt in this way, but we're going to continue to do it because that's our history and that's who we are.
Thank you, Dr. Shand. That is so helpful. Have we gotten to the end of the questions? I'm just mindful of the time.
Yes.
I told you we'd let you go for 30 minutes, in 30 minutes, because I'm mindful of your schedule, but also, is there, I think what I might say is, are there any other questions for Dr. Shand before we let her go? And then what we'll do is have a community conversation at this point. Glenn Mahaffey, are the medications improved to treat people who have been infected and are ill? I guess long haulers.
So short question. In the acute phase, there is an antiviral medication that looks like it's going to be pretty effective in shortening the course of people who are ill. And I think we'll be hearing more about that, in the news in coming days. So that's in the short term, something similar but not exactly the same as Tamiflu, because Tamiflu is okay but not great. And then improved to treat people so long haulers. That's a different conversation for a different day. Less of an emphasis on antiviral medication for long haulers, but really understanding and supporting the parts of the immune system that have gone awry in folks who are dealing with persistent symptoms several months after having COVID infection. But I will say there is an antiviral drug that looks extremely promising and is probably going to come to the bedside very soon. There's a lot of talk about that in my community for adults with cancer who are immune suppressed, who it may shorten their hospital course and make things better for them. So far, that's what we know. We know that steroids like dexamethasone are also very helpful, and the way that we help folks through breathing support. So those are the things. Ivermectin is dangerous, and it has been proven again and again not to be effective. And I'm sorry, but it's just really important for me to say that, because the courts are telling us as physicians that if someone wants ivermectin, we have to give it. And that's a real ethical and moral dilemma for us, because it's not proven and it may actually be harmful, which goes against the professional and ethical code. So I just would ask you one small favor, which is not to put ivermectin in that category of things that may be helpful.
Thank you. Thank you very much. And then, Toppy, I so appreciate Dr. Shand's holistic perspective, reminding us of the struggles of the Israelites. All right, so putting it all together for us. Well, Dr. Shand, thank you. We will be in touch, and might do one of these again, maybe in February or March, once we see a little bit what's happening in the winter. So
Yes,
we'll be in touch. So
count me in.
Thank you so much. And thank you so much for your wisdom. Blessings to you.